Okay, guys, there is something called carpal tunnel syndrome, in which there is a nerve here called the median nerve, in which it gets basically trapped inside of the carpal tunnel, and there is going to be a lot of compression to it, which is going to impair its function. The first thing to appreciate about carpal tunnel syndrome is to know which type of people are at high risk of getting it. So who do you think? Who do you think is at high risk of it? Oh my God. Well, yeah, well, it could be. But the alcoholic high tech? Okay. So it's mostly high tech people. That's true. And also people with end stage kidney disease, and also people with hypothyroidism. You are like, how come things are associated with each other? Hypothyroidism love to create something called glycoaminoglycans, which can accumulate inside of the canal and lead to compression of the median nerve. High-tech people, they put their hands in such posture all the time because they are writing on the keyboard, And to make it worse, this is like looking at it from the side. Basically, this is their hand. This is their palm. So they are compressing the canal. To make it worse, they are not only compressing it, they are compressing it like this and like this, because the keyboard is like this, right, guys? So we put our hands like this. So you are twisting the joint twice all the time. So what is the solution? There is multiple things you can do. One of them is a split keyboard, actually. Yeah, a split keyboard. Yeah, something like this. So in this way, you can have both of your hands comfortable with each other without the need of, making it work too much. Also, the programmers, we have this type of keyboard for them. This is also help with the median nerve compression. Yes. So let's move on. There is something called, the hand muscles. Remember, there is two areas in the hand. There is the thinner eminence and the hypothinner eminence. So when we speak about the thinner, remember, thinner is near the thumb. Thinner thumb. Hypothinner is the other one. So yeah, hypothinner is here, thinner is here. They are important because they are supplied by different nerves. I mean, if I'm speaking about let's start with the hypothinner. Do you remember which nerve supplies the hypothinner? We are looking at the palmar side. The radial nerve only supplies the dorsal side. So that was going to be absolutely the ulnar. Yes, remember, 1.5 finger. Okay, what about the thinner? The thinner. No, radial only supplies the dorsal side. Yes, it's going to be the median. So if you look at behind of the hand, the posterior side of the hand, because this is the anterior side of the hand, you look at the posterior side of the hand, then you are right, it will be radial. So let's take a look what they write here. The thinner portion, the median, is supplying the following muscles. The abducens pollicis, abductor pollicis, pollicis brevis, flexor pollicis brevis, and superficial head. And deep head by ulnar. So let's speak a little bit about this stuff, because some of them are important, some of them are not. There is a motion of the hand that is called a position of the thumb. Okay, they like to ask about this, a position of thumb. They show you a picture of a position of the thumb. Let me just find a position. Okay, just a moment. Basically, a position of the thumb, it's when you see the thumb, you are doing the opposition, which is bringing it in to your hand. And this function is mediated by the median nerve. So a position of the thumb is bringing the thumb and bringing it in. So as you can see, this guy, he's doing a position of the thumb, and it's mediated by the median nerve. Okay, so this is a way to check the median nerve function. Position of the thumb. Okay, good. So a position of the thumb is mediated by the median nerve. The next thing that I want you to know that it's all about the location, guys. So when we are speaking about this area of the hand, obviously it's by the median, even the muscles. If you are speaking about the little finger, the little finger, it is going to be the ulnar. And how do you say little finger in Latin? You say digiti. Digiti means finger. Minimi. Minimi means small. So yeah, the thing that leads to apposition, abduction, and deflection of the small finger is going to be the hypothenar. The thing that is leading to the apposition, abduction, and deflection of the rest of the finger is going to be the median nerve. Okay? So again, median nerve, apposition, abduction, and deflection of these fingers. While the small finger, right, the pinky, it's by the ulnar. All of the function, apposition, abduction, and deflection. So when you bring this finger and this finger together, you are actually checking both the median and the ulnar nerve function. So there is something known as denser interosseous muscle, which abduct all fingers, and palmar interosseous muscles, which helps in the adduction of the fingers. So both of these are supplied by the ulnar. Finally, there is something called the lumbricalis muscle. Lumbricalis muscle are also located between the fingers. They also help in the flexion movement of some joint and the extension of other joint. So before speaking about all of that, I just want to refresh your mind about the joints of the hand. So some joints of the hand, okay, yes, good. So you can see here the DIB, we call them, distal interphalangeal joint, this guy. Then you see the PIP, which is proximal interphalangeal joint. Then you see MCB, which is the metacarpal phalangeal joint. And then you see metacarpal joint. I want you to know that this one, the carbometacarpal joint, is the one that is mostly having the arthritis in case of hemochromatosis. While if we're speaking about the DIB and the BIB, both of them can be affected by osteoporosis, while only BIB is going to be affected by rheumatoid arthritis. So rheumatoid arthritis is not going to affect the DIB. Okay? We are going to relearn all of this when we discuss each disease at a time. I'm just giving you a quick overview of all of that. So they write here the lumbricalis muscle. The first and the second ones are supplied obviously by the so the first and the second, this is the first, this is the second. It is going to be the median, while the third and the fourth is supplied by the ulnar. They help in the flexion process of the metacarpophalangeal joint. What I want you to know about the metacarpophalangeal joint, if you look at your hand and you make a fist, you can see this thing. We call them the knuckles, okay? The knuckles. The knuckles is the other way of saying MCB, metacarpophalangeal joint, okay? So just, if I was you, near MCB, I'm going to say, write metacarpal phalangeal joint. I'm going to write knuckles. In the same time, it's true that it's like flex the MCB, but it helps in the extension of the BIB and the DIB, which basically means he's flattening flattens the fingers down there. Just make them straight. So disorientation of the hand. So we have something called the bob hand. Maybe you heard about it. There is something called the okazisha. Some of these are new actually, but what I want you to know is the general theme. So what they write here, disorientation of the hand. At rest, we have an equilibrium, a balance between the extrinsic flexor and the extensor of the hand, which keep everything in the place, okay, as well as the intrinsic muscle of the hand. So because of that, our hand is stable. If you look at your hand, it's stable. Mostly a little bit flexed actually. Mostly our hand is a little bit flexed, but in general, it's stable. There is no one predominating the other. So particularly the lumbricalis muscle. A flexion of the MCB, remember what we spoke about the lumbricalis muscle. So they flex the MCB, which was the knuckles, they flexed them. Flex them mean bringing them closer to our body, right? But they extend the DIB and the BIB. If you don't understand what that is, just look at your hand now. Your hand now is rested. You can see that like near the knuckle, it's a little bit flexed alone without you doing anything, right? While your fingers themselves are more straight. They are much more extended than, just put your hand in front of you and look how the knuckles is a little bit flexed while your BIB and DIB are a little bit extended. So, of course, it's not 100%, but still, nothing is perfect. Okay, so let's see what is clawing. Clawing of the hand, basically. So clawing of the hand, seen best with distal lesion of the median and the ulnar nerve. So what is the idea of clawing? We are going to speak about it here in details, but let me just see if they like bring something new here. Remaining extrinsic flexor of the digits exaggerate the loss of lumbricalis. Okay, so let's speak about each nerve at a time from the one they are mentioning here. So when we are speaking about a distal lesion of some nerve, you can either have a distal median lesion or a distal ulnar region. At both of these, take a look. There is a claw, there is a claw. What is a claw? A claw, it's in the animals. You remember like some animals have claws which help them to tear their victim, right? So yeah, claw. So look at the hands. They are flexed in this fashion, which makes it look like they are having claws to destroy, you know? So let's start with the ulnar. When the ulnar normal function, well, it's supposed normally, what is the ulnar supposed to do? To flex the finger, right? So, okay. And basically he will become dysfunctional. So you cannot, and also extend. So if you try to flex or extend the fingers, I mean the ulnar, can you extend them? The answer is impossible. So they will be stuck in this fashion, as you can see. They will be stuck like this. So if you, basically this will happen only on the extension of the fingers. So you tell the patient, can you please extend your fingers, sir? His median nerve and radial nerve are intact. So he can extend his 1, 2, 3 fingers with no problem. But these 2 fingers, because basically his ulnar nerve is gone, they will not move. They are fixated in the place. So yeah, when he tries to extend his fingers, his little finger, or his 4th and 5th finger, will not move, which make it looks like a claw. So only you will see such thing on when he tries to extend his hand. Okay, good. But this is, remember, this is a distal lesion, Okay, so let's see what they write. Clawing is seen best with distal lesion of the median and ulnar nerve. Remaining extrinsic flexor of the digits is going to exaggerate the loss of the lumbricalis. So yeah, the fingers are going to extend at the MCB. Remember the MCB, it's the ones near the knuckles. These are going to be extended while flexing the DIB and the BIB, which creates you the claw-like feature. When you speak about these things, try to do them on your hand, because otherwise you will not get it. So again, you extend your knuckles, okay? And at the same time, you flex your DIB and your BIB, okay? So, the next thing, they write here, deficit, deficits less pronounced in the proximal lesion. Deficits presents during flexion of the digits. So let's just try to take a proximal lesion and discuss what are the changes. Actually, I don't like how they do it here. So I'm going to discuss each nerve at a time. We discussed the distal ulnar nerve lesion. Let's discuss the proximal ulnar nerve lesion, which is this one. So you tell the patient, remember, his ulnar nerve is not working. So he cannot extend his hand, he cannot he cannot extend his pinky, he cannot flex his pinky. So you open his hand up for him, you open it up and tell him, make a fist for me. Okay, so when he tries to make a fist, finger 1, 2, 3 are intact. Why? Because the making of the fist requires flexion, which is the function of median nerve in these 3 fingers. But what about these 2? Which nerve is responsible for the flexion movement in these 2? The ulnar. Because the ulnar is the one responsible for that, if you tell him to make a fist, can he make it? He cannot. So they will be stuck like this. So yeah, making a fist, proximal ulnar nerve lesion. Okay, so let's discuss the last two here. So we have the proximal median nerve lesion, proximal median nerve. So it's up. Remember, when I say something is a proximal, so it means it's closer to the body. So if I have a human being like this, okay, my drawing is bad, but basically if the lesion is here, it's a proximal. If it's here, it's distal to the body. So a proximal median nerve lesion, again, the same guy, you tell him to make a fist, but now his median nerve is gone. So when you tell him to make a fist, his ulnar nerve will be functioning normally, which is going to do what? Well, flex the small fingers. But what about the other ones? They will not move. In the distal nerve, distal median nerve dysfunction, the same idea. He's going to be at rest, well, like this. And you are going to tell him, well, can you try, well, a little bit flexing his finger, not much. You ask him to extend his finger after you made a fist from his finger. You just grab it, put it all together, it becomes a fist, tell him extend it. So the first two fingers are going to be extended because ulnar working perfectly, while the rest of the hand cannot do so. So that will create a claw as well. So yeah, after you, let's say that this is a muscle, and you have a nerve supply of the muscle. If you cut the nerve, after some times, what happens to the muscle? What do you think? It atrophies. Look, if you decrease the blood supply, if you decrease the nervous supply, in both cases, the muscle will atrophy. If you decrease the hormonal supply of a tissue, it atrophies. Atrophy of the thenar eminence, remember, thenar, it was near the thumb. So, near the thumb, is it median or ulnar? Near the thumb? Median, absolutely. So, it can be seen in median nerve lesion, while atrophy of the hypothenar can be seen in the ulnar nerve lesion. So by just looking at the thenar and hypothenar, you can say for sure which problem this patient had. So when you take a look at this guy, you can see atrophy of the thenar. Which nerve are you thinking about? Atrophy of the thenar. Median, absolutely. When you take a look at I'm not, okay, good enough. So look, this one is normal, this one is atrophied. So what does this patient have? Ulnar. To make you like understand this more, this patient is trying to extend his hand to show the camera. So his fingers here are extending with no problem, here with no problem, but can you see his little fingers here? I mean the small one and this one, the ring finger and the little finger. He's unable to extend them because his ulnar nerve is damaged, correct? Yep. Okay, good. It's quite more common actually, guys. Okay, guys, if I cut the nerve, if I have a nerve, median nerve, and I decide to cut it for some reason, I don't know why, but I cut it. Can it regrow? Yes, it can. Absolutely. So this is a tricky question because you've been taught that the neurons do not regrow. That's true in the CNS. But if we are speaking about the BNS, they do. Do they require a lot of time or not a lot of time? A lot of time. Let me tell you the approximate number. It's 1 centimeter per 6 months. Per 6 to 8 months. 1 centimeter per 6 to 8 months. You are like, wow, that's actually not that bad. Well, it is that bad because imagine this hand to get re-innervation from here to here. This is around, I don't know, maybe 12, 13 centimeter. So that will take maybe 8 to 10 years. Okay? So that's a lot of time. To make it worse, a nerve like the sciatic nerve is more than a meter long. So if you cut the distal portion of it, for the sake of it to regrow, you will need 100 centimeters. So that will take you around, I don't know, maybe 30 years. So yeah, they do regrow, but they take a lot of time. So what is the best thing you can do? If you cut a nerve, take the distal portion of the nerve and put it near the proximal portion of the nerve and put one suture here. Okay? So they were going to reattach together and regrow each other. Hopefully. Does not always work. So here they are giving examples about abductors and adductors, extensors, flexors, internal rotation and external rotation. Remember, if I draw this guy and he's moving his hand away from his body to this side, is he abducting or adducting? He's abducting, absolutely. So the B facing the D, so opposite to each other, he's going away from the body. Gluteus medius and the gluteus minimus do that. Okay, which is in the buttocks basically. Adductor bring it closer to the body. For example, adductor magnus longus brevis in the lower extremity. Extensors, basically they extend. When I say it extend the organ, it basically means it push it away from your body. I'm going to try to trick you now, so try not to get tricked. So this is a human being. This is his hand. Okay? This is his arm. This is his head. If he moves his hand closer to his body to this side, is he flexing his hand or extending it? What do we call this movement? Flexion. What about this movement? This other side movement is going to be extension. Yes. Now comes the tricky question. Let's imagine that this is his legs, okay? So this is his knee basically. This is his knee. Okay, so when he moves his foot, I mean his leg from here to here and make it flat basically, how do we call this? What he's doing to his leg? Excellent. He's extending it, pushing it away from his body. Okay, when he bring it closer to his body to this side, how do we call it? Flexing it. Excellent. Good. What about his thighs? When he moves his thighs to this side closer to his body, how do we call this? No, that's wrong. I told you, when you bring something closer to your body, it's a flexion. Flexion is moving it into your body. I'm flexing my thigh to my abdomen. I'm extending my thighs away from my abdomen. Okay, good. So they give examples here. We have extensors and flexors. They give here again a gluteus maximus, semitendinous and semimembranous muscle in the back of the thigh. They also give flexors here. We have iliopsoas, which is a muscle that comes from the vertebrae and go all the way to the thigh bone. And also we have rectus femoris, tensor fascia latae, pectineus, and sartorius. Some of these I have to tell you their names and what do they mean. Iliopsoas is a muscle coming from the abdomen and going all the way to lower extremity. It is important. Why? Because it passes through the iliac fossa. So in case of appendicitis, if you extend the leg, the psoas muscle is going to be pushed forward, which is going to irritate the inflamed appendix. So we have a sign called the psoas sign, which means the patient is going to have pain upon extension of the thigh because it compresses the appendix. Okay, so the next thing I want you to know, the word rectus in general means straight. So if you look at the rectum, I mean in the GI, he's straight. If you look at the rectus muscle in the eye, they are straight. If you look at the rectus femoris, he is straight. Okay, good. So we have internal rotation and external rotation. Some muscle help you to push the limb inward and or outward. Inward, we have gluteus medius, minimus, tensor fasciae latae, which is quite a long muscle. Latae in general means white. External rotation, like iliopsoas and gluteus maximus, piriformis muscles, and iptiroter. I'm going to show you one group of muscles, and I'm going to give you like a common question they ask. They are going to show you the posterior group of the muscles inside of the lower extremity, and they are going to ask you the following. Which of the following is not a part from the lower extremity muscle? So they are not going to show you the picture. They are literally going to ask you this. Which of the following is not a muscle of the posterior? They will speak about the surgeon, and the surgeon is trying to reach the sciatic nerve or something like this, and they tell you which of the following muscle is not in the posterior, basically, compartment of the thigh. So please know that piriformis, gemellus inferior superior, and obturator and quadratus femoris are posterior. You don't have to know each name. You should only be able to recognize them. You should recognize where each group is located. I want you to have the general idea in your brain that in the lower extremity, we have the following idea. So you have, this is the thigh, of course. You have anterior compartment, you have posterior compartment, and you have an adductor compartment in the thigh. While if you speak about the leg a little bit downward, you have an anterior compartment, you have a posterior compartment, and you have a lateral compartment. So again, anterior, posterior, and adductor, right? Or also known as medial compartment if you want. Medial compartment. Well, here it's anterior, posterior, and lateral. The same thing with the arms, but that's not our topic. So, good. So this is in general, the general idea. So whatever I just told you guys about is just some general principles type of thing. Now that will be useful for us when discussing the lower extremity nerves, which we are going to speak about after the break. So see you guys in 10 minutes. So we were speaking about the extensors, flexors, adductors, all of these. Before I jump to the next thing, I have a question regarding the innervation of some muscles. We said that if a muscle loses the blood supply or the innervation, what is going to happen to the muscle? Atrophy. Can somebody tell me the mechanism of atrophy? How does atrophy occur and what does it mean? Somebody said apoptosis. You are right. And also, one more thing. In the apoptosis, like it's a programmed cell death, and also there will be something decreasing the cytoskeleton. How the cytoskeleton will be destroyed for the cell to shrink. There is a system that works that leads to shrinkage. The ubiquitin proteasome pathway. Absolutely correct. Good. So, let's take a look at the lower extremity nerves. We have the first one, the iliohypogastric one. It has two main innervation. It innervates two things, two main functions. So I just want first of all to show you this. If you remember, we spoke about something called the brachial plexus. Like the brachial plexus, there is something known as the sacral plexus, okay? Or sacrolumbar plexus. In the sacrolumbar plexus, it has, as you can see, it's just a mess. There is so many things coming out of it. But, like I do it always, I don't look at all of them at the same time because I get confused. I look at one at a time. So the first one here is the iliohypogastric. That's our problem for now. So in the iliohypogastric one, this guy, it's going to have both sensory and motor innervation. If we speak about the sensory, it can have innervation of the suprapubic region of like sensation type of thing. And if we speak about the motor, it can have innervation to the transversalis abdominis and internal oblique, which are the muscle of the abdomen. If you bring a knife and you stab somebody in his abdomen, if this is his abdomen, this is his umbilicus, and you stab him here. Which muscle are you going to penetrate? The answer is the following: external oblique, internal oblique, and the transverse abdominis. And if you stab him here, let's say that this is the umbilicus. So yeah, the first stab was here, but if you stab him here, the exact same one, in addition to rectus abdominis. Okay? So let's take a look at that. You can see here the linea alba, this is the umbilicus, and you can see here the rectus abdominis. Under it, you can see this transversalis abdominis. Okay. So they write, it can be damaged in cases of abdominal surgery, and when it's damaged, you are going to have neurological pain. What is neurological pain? A burning or tingling pain in a surgical incision site, radiating to the inguinal or the subpubic region, which were normally supplied by the sensory branch of the iliohypogastric region, iliohypogastric nerve. Is this nerve really important? Not really. Why it's important? You will know in a second. We can utilize it for something else, basically. So we have the genitofemoral nerve. Genitofemoral nerve, which is the nerve just under the iliohypogastric nerve. As you can see, the ilioinguinal one. It's the second branch. And this guy is going to, it's a little bit more important because it supplies the scrotum and the labia majora in addition to the medial thigh. Also, the cremasteric muscle. It's important. Why? Because this one can increase, this one as well can be utilized in special cases. For example, let's imagine somebody had some form of a surgery and you damaged the main nerve that goes to the clitoris in a lady. So she will not have, any more sensation, as a sexual sensation. Can we fix that? The answer is yes. How can we fix that? Well, you can utilize the genitofemoral or the iliohypogastric to that side. We don't prefer the iliohypogastric because it supplies so many muscles. We prefer to use the genitofemoral, in which we will cut that nerve, attach it to the nerve that normally goes to the clitoris, and in that way, the clitoris is going to get its innervation back. But you are like, but wait a second, you just said that it innervate the medial thigh. That's true. So this patient who's going to regain the sensation of her clitoris, it's going to lose the sensation of her medial thigh. So you will tell her, it's kind of like, get something, lose something. Would you like to do it? And sexual sensation tend to be some serious thing, and many patients will agree into that. So, motor in men, it can move the cremaster muscle, which means that you can test if this nerve is intact by checking the cremasteric reflex. If you don't know what is a cremasteric reflex, see this guy? Basically, it is you bring a patient, male patient, not female patient, and you basically just scratch the inner portion of the thigh, and after you do that, the scrotum is going to ascend, as you can see. He's going to tell you that he sends a seed, so that's what exactly happens. You just need to scratch it, and the testicle are going to crunch up. And that means basically that the genitofemoral nerve is intact and he's working perfectly. Good. It can be damaged in cases of laparoscopic surgery. I'm not saying abdominal surgery such as in laparoscopy, like laparotomy. We are speaking about laparoscopic surgery in which we use a laparoscope, which is a device in which we make multiple holes in the abdomen for the sake of gaining entrance into the abdominal cavity. So there will be a decrease in the upper medial thigh and anterior thigh sensation beneath the inguinal ligament, under the inguinal ligament. Okay, so this one was over the inguinal ligament, this one under the inguinal ligament. And and the most important thing that in case of its damage, you will not have a cremasteric reflux. Okay, so you can check the cremasteric reflux for the sake of checking if the genitofemoral nerve is functioning or not. The next one is quite really common, especially in the US. So it is basically the lateral femoral cutaneous nerve, and this nerve normally supplies the anterior and the lateral thigh. So it's normally going to get compressed by titiclodus and lateral cutaneous. Yes, titiclodus, especially in an obese patient. In these obese patients, they tend to, if they wear really titiclodus, they are going to compress their inguinal nerve, which is going to compress the lateral femoral cutaneous nerve, which is going to lead to an impaired sensation of the anterior and the lateral portion of their thigh. So they write, titiclodus, obesity, pregnancy, and pelvic apresthesia, we're going to damage the lateral femoral cutaneous nerve, which is decreasing the thigh sensation and the anterior and lateral sensation of the thigh. Obturator nerve. The obturator nerve has two portions, a sensory one and a motor one. The sensory one is going to do the medial thigh. So the lateral and the anterior was by the lateral femoral cutaneous one, and the obturator for the medial thigh. The medial thigh also is going to basically having some muscles in it, including the adductor muscles. If you remember, we spoke about the adductors. I told you about the medial group of muscles in the thigh. So the thigh has 3 groups and the leg has 3 groups, right? So here we had anterior, posterior, lateral. Here we had anterior, posterior, and basically adductors / medial group. So the motor, the obturator externus, adductor longus, adductor brevis, gracialis, pectineus, and adductor magnus. All of these help to bring the leg inward. Pelvic surgery can damage them, which decreases the sensation and the adduction. Remember, the adduction was the function of getting the leg close to the median line. So, femoral. The femoral, it's basically, you need to understand where it comes from first of all. So let me show you that. Okay, good. So the femoral nerve comes from, multiple nerves coming together, multiple branches of spinal nerve coming together, which create us the femoral nerve. So you can see here iliohypogastric, and you can see which supplies the suprapubic area, ilioinguinal, and also, basically they are the same branch for the same one, genitofemoral, which used to supply the scrotum, the labia majora, and the medial portion of the thigh. Lateral cutaneous, which anterior and lateral thigh, as we said. And let's continue. So this is for you guys. And the obturator, we said about the adductor muscles. So the femoral one, when it's damaged, it has it supplies 2 things. So sensory and motor again. So sensory, anterior thigh again, and medial leg. Because basically when you take a look at it, it's going to be more apparent for you. I hope there is a good picture for this here. So if you check just nerve distribution, okay, that's good. So that's the lateral femoral one, and this is the anterior femoral one. So it's going to be this portion and this portion. So let's take a look. Okay. So yeah, this portion and this portion. So let's see. Medial leg and anterior thigh. This portion, that's it. And yeah, the motor one is going to be the quadriceps, iliacus, pectineus, and sartorius, which all of them are a portion of the anterior compartment of the thigh, So let's imagine that this is the tibia of the leg, this is the joint, which is the knee joint, and this is the femur. I told you that the anterior group is the one messed up. So the anterior group is normally responsible for what? What is it responsible of? If this is stretched, what is going to happen to the leg? Flexed or extended? What do you think? Extension. Extension. Look, if this is the muscle and it's going to contract, it's going to pull the leg upward, right? Which means making the leg flat, which means extending it. So in case of a damage of these muscles, we have less extension and less patellar reflux. Why? Because the quadriceps is missing. So the quadriceps muscle has 4 heads, and it's located at the anterior compartment of the thigh, as we said. So this is the muscle. So it's connecting to the tibia, to the patella, as you can see. And if it's dysfunctional, the patient basically cannot extend his leg. Good. So the next thing we have here is the sciatic nerve. Sciatic nerve is super important because you are going to see it on a day-to-day type of thing, because so many people have a problem in it. So the sciatic nerve, we have the motor one, motor innervation type of thing only. Well, it has sensation as well. They don't mention it here. Why? Because actually the sciatic is going to be subdivided into 2 other portions, the tibialis and the common fibula. So the sciatic in general, the motor stuff for it is going to be the semitendinous, semimembranous, biceps, and adductor magnus. Again, remember when I told you that there was an anterior compartment of the thigh, a bone, and a posterior compartment of the thigh? Anterior compartment was supplied by the femoral nerve. Posterior compartment is going to be supplied by the sciatic nerve. So for the sciatic, herniated disc can lead to sciatica, which is a pain in the sciatic, which is due to compression of the sciatic nerve. And posterior hip dislocation as well, which is most commonly happen in all people. Herniated disc happens mostly when you are trying to hold a really heavy object from the ground up. So it's really common in men, especially those who work in heavy duties. So splits into the common peroneal and the tibial nerve. Yes. So if you look at the sciatic nerve, if you look at the sciatic nerve, oh yeah, good. So you can see how the sciatic nerve can supply so many muscles. All of them are in the posterior compartment of the thigh. And this is also going to divide into the common peroneal and the tibial. Keep in mind that the sciatic nerve is always held by the piriformis muscle. If the piriformis muscle was overstretched, over contracted, what is going to happen to the piriformis muscle? The piriformis muscle was contracted. If the piriformis muscle was contracted, what will happen to the sciatic nerve? Compressed. Yes. Is it going to be painful? Yes. So guys, your job as a doctor is to relax this muscle. Yes, massage can relax it, but it's a passive type of relaxation, which means the moment you finish the massage, the pain will come back. So what you have to do? An active massage. What does an active massage mean? Basically, it means that you bring the patient and you teach him how to do exercises for this. You won't believe the number of patients who come to me complaining of sciatic nerve stuff. Relatives, family members, a lot of people who come to me and be like, oh, I have this sciatica. I went to so many doctors, nothing helped. I take this NSAIDs to decrease the pain. And he's right. Because most of our today type of treatment is all about pharmacology. People forget about the most important thing, which is what? Which is sport and lifestyle modification. So lifestyle modification goes something like this. The lifestyle modification in this case is going to be the piriformis exercises, we call them. So piriformis exercises are going to relax the piriformis muscle. So will the sciatica be compressed anymore? The answer is no, not really. So yeah. Okay. All good. the next thing to speak about now, let's take a look. Okay, good. So we said that they basically split into the common peroneal and the tibial nerves. And when we're speaking about this, it goes something like this. We have the common peroneal or the fibula. We have superficial peroneal nerve, and that one has a sensory and a motor. And we have the deep one, which also has sensory and motor. I'm really sorry, but you have to memorize both superficial and the deep, and which one supplies which sensation to which area, and the deep for which area, and the motor, what does it supply, and the deep, what it supply. It's not as difficult as you think, though. So if you speak about the superficial, it has sensory and it has motor. The sensory is all of your foot, the whole thing, okay, except the small area like a triangle between the hallux and the second digits. So let me show you what does this look like. Yes, can you see it? This is the superficial peroneal nerve, and this is the deep one. The deep one is just a small portion between the two fingers. So that give you both of the superficial and the deep one. The common supplies the upper portion here. Okay, so superficial one, sensory, all of the things except this small area between the hallux and the second digits. While the deep peroneal nerve is sensory as well. It has sensory which only supplies that one area that was not supplied by the before one. The motor, however, supplies the... Remember when I told you that there is a 3 compartment in both of the thighs, and also there is a 3 compartments in our leg itself? So the lateral compartment, known as the fibular compartment, contains 2 muscles which are known as peroneus longus and peroneus brevis, also known as fibularis longus and fibularis brevis. So let me show you these muscles. So yeah, this is the lateral compartment of the thigh, as you can see, and it contains the brevis et bravus peroneus. Yes, so it's the lateral compartment. Good. What about the motor one? Tibialis anterior. What about tibialis posterior? Well, remember when I told you sciatica subdivide into a common peroneal and a tibial nerve? So the common peroneal supplies all of this. The posterior tibial, or the tibial, is going to supply the rest. Okay? So let's take a look here. Trauma or compression of the lateral aspect of the leg and fibular neck fracture. Why fibular neck fracture? Because the common peroneal nerve go exactly near it. So let's just take a look at the common peroneal nerve. As you can see, it just go near the fibula head. So fibular neck fracture is going to damage the common peroneal nerve. Remember, common peroneal nerve is a branch of the sciatic nerve. Okay. The trauma or compression of the lateral aspect of the leg and fibular neck fracture. So we have the PED. So peroneal nerve is going to avert and dorsiflex. If injured, foot will be dropped. So if you damage the peroneal nerve, your foot will be dropped. Dropped, I mean like down all the time. Which means if your foot is dropped, can you walk on your fingers? I mean, can you walk on your toes? In that case, can you walk on your toes? Okay, good. Can you walk on your heels? Good. You cannot walk on your heels, correct? So that's what they say. Foot, loss of sensation of the dorsum foot as well. The foot drop inverted and the plantar flexed at rest, loss of the aversion or dorsiflexion. So they will have this steppage gait in which they will literally be slamming their leg to the ground. Okay, so I hope I'm going to find a good Video of Stabash gait. Common. Okay, let's take a look. Hopefully we can find an actual, yeah, slap gait. Exactly, they are going to slap their leg into the ground. So take a look at this one. See, they rise their leg excessively for the sake they are going to rise their leg excessively for the sake of getting the whole thing down. How come? Why they are doing this? Because if not, they are going to step on their own fingers. Okay, so that is the idea of step. See, look at his finger, it's dropped, so he has to rise it a little bit over. So he's going to, it's basically this leg, guys, this leg. See, so he must rise it a little bit for the sake of just not stepping on his fingers. Yeah, like a duck, exactly. Good. Good, actually, good idea. I never thought about it like that. Okay, let's speak about the tibial, which was the other branch from the sciatica. So it also has a sensory and also has a motor. Sensory, well, it's going to be the sole. But you are like, well, you told me that the whole thing was supplied by the common peroneal. Yes, except the sole. The sole is like the down face of the foot. And the motor is going to be the biceps femoris, long hip, and also triceps suralis, plantaris, popliteus, and the flexor muscles of the foot, which are all of them actually, all of them are located at the posterior leg. Okay, all of them are at the posterior leg. So knee trauma or a Backer cyst, I will show you this, or tarsal tunnel syndrome. Tarsal tunnel syndrome is like carpal tunnel syndrome, but in the leg. So first of all, let's take a look about Backer cyst. And I want you to know what also happens in case of its rupture. So this is a Backer cyst. It's basically a synovial fluid filled cyst that can compress the tibial nerve. Okay? What I want you to know that if the Backer cyst is going to rupture, what is going to happen? Imagine this. This is going to rupture. So the fluid from it is going to seep down the leg. It's going to go down the leg, right? So it keep going down the leg until it reaches here. And when it reaches here, it makes this line. Can you see the dark line? This is basically the cystic fluid inside of the leg down there. And this is a sign of Backer cyst rupture. It's not dangerous, it's painful, it's not dangerous, and it's going to have full resolution after that. Just keep in mind, oh yeah, this thing. Can you see this dark area? This is because of the Backer cyst rupture. Yes. Just keep in mind that it's painful, but it's not lethal, which means what you are going to do about it, the answer is absolutely nothing. Just give him some NSAIDs, right? Not for the pain. What is the best NSAID for the bone? I mean, what is the best NSAID for joint pain? Ibuprofen is good, but it's not that strong. You should know there are some NSAIDs for some things. For example, paracetamol is not even an NSAID, but he's the best for fever. Ibuprofen is the best for mild to moderate pain. Indomethacin is the best for inflammatory internal condition like pericarditis. Diclofenac sodium is the best for bone. Okay, diclofenac sodium is the best for bone and joint pain. Okay, let's speak about the tip, just the tip. So tibial, invert, and the plantar flex. Why we said that? Because the dip. So we have the dip and we have the tip. So the dip was what? The bid, peroneal invert and dorsiflex. And the tip, tibial invert and the plantar flex. Okay, so these patients will have many problems in the muscles that basically supply the posterior portion of your leg. If that is the case, can you plantar flex your foot if they were damaged, if this nerve was damaged? Can you plantar flex the foot? The answer is no, because this group of muscle, which is responsible for plantar flexion and drawing the leg upward, it's gone. If you cannot do so, can you walk on your toes? You cannot walk on your toes. Can you walk on your heels? Wait, why we cannot walk on your heels? This is functional. This is functional. Dorsiflexion is working. So dorsiflexion is working, so you can still walk on your heels. You just cannot walk on your toes. Okay? Inability to curl toe because of loss of sensation of the sole. In a proximal lesion, the foot will be averted at rest with weakened inversion and the plantar flexion. Basically, if you look at the foot, in case of tibial palsy, it will look like this. Weird, I can't find an actual picture. Ah, good. Here you go. Yes. Okay, good. Nice. So the leg, it cannot be, basically what will happen in this patient, because they cannot plantar flex, their foot will always be going up, right? It's always going up. And because they cannot invert it, which means put it inward, it's always going to be everted, which means going outward. Okay? Okay. Superior gluteal. Everybody like this one. So superior gluteal is going to supply the gluteus medius and the gluteus minimus. What about the maximus? The maximus is supplied by the inferior. Okay. What I want you to know is, actually they only ask about one thing about this, which is the test. So let's leave it to the end. Iatrogenic injury, which means during like some type of medical procedure. During intramuscular injection. Oh yeah, remember? By the way, guys, when you want to give somebody an injection, you need to know how to do it. So, injection in the buttocks. You need to know where to put it. So first of all, you separate the one buttocks into 4, and you hit at the upper lateral portion of the thigh. You are like, well, why? What if I hit here? Well, if you hit here, you are going to get a lawsuit because you are going to hit the sciatic nerve. So always hit at the upper lateral portion. General ideas. If you get an injection that is 3 millimeters, give it in the deltoid muscle in the arm. If it is 5 millimeters or more, you must give it in the buttocks. So, next. Yes, so they say you can prevent it by choosing the superior lateral quadrant, preferably the anterior lateral region. So you will not hit the this guy. So yeah, you can either hit it here or from the side, basically. This is the best two locations. So the side also can work, which is here. Okay, this is the anterior lateral one. Good. So they say the way to check this muscle function and this nerve function is by something called Trendelenburg sign or gait. So you bring the patient and tell him, okay, stand in front of me. So he stands in front of you. And then you tell him, okay, can you please rise one leg? Okay. Normally when he raises his leg, the other muscles should be contracted, which is going to leave you with a straight line at the iliac crest. But in case of a lesion to these muscles, there will be a misalignment. Okay. So pelvic tilt, because of weight-bearing leg, cannot maintain alignment of the pelvis through the hip abduction. Lesion is contralateral to the side of the hip that drops. So ipsilateral to the extremity on which the patient is stand. I just remember this. When in Trendelenburg sign, you are stepping on your vein. Okay? You are stepping on your vein. What does that mean? If this patient is having this tilt, it's a positive sign. Where is the nerve pulse? Is it on the right or in the left in this patient? What do you think? You are stepping on your vein, so he's stepping on his right leg, so the pulse is in the right side. Again, let's take a look at another Trendelenburg type of situation, Trendelenburg sign. Okay, so this guy, what do you think? Is he having the problem on the right side or on the left side? Left side, because he's stepping on his bane, right? So the left side is going to have the palsy, the positive sign when you lose the alignment. Okay, the next thing, inferior gluteal supplies the gluteus maximus. They love to tell you about the lady, old lady, that she cannot go down the stairs. That's one. Or second thing, she cannot go up from her chair. Okay? Why old lady? Because old ladies are more likely to get a posterior hip dislocation after a fall. So yeah, difficulty climbing the stairs, rising from the seated position, and loss of the hip extension, which is pushing it away from your body. The pudendal nerve. Pudendal nerve has sensory and motor. The sensory sublimate go to the perineum. Perineum is basically like the peritoneum, but in the pelvic cavity, okay? So if you remember, we have this membrane, the peritoneum, that was inside of the abdomen, but in the pelvic cavity, we have perineum instead. Also, it supplies the external urethra and anal sphincter, which allows us to basically control our feces and urination. You can check if it's working by checking the anal wink reflux. The anal wink reflux is basically like you put a finger and you put it near the anus, and the anus is supposed to close down. So stretch injury during childhood, and prolonged cycling as well, and also horseback riding for a long period of time. Okay, because of repeated hitting of the nerve. So the patient will have less sensation in the perineum and the genital area in general, because the S2, S4 is going to be like, you know, when you ride the horse, all of that area that the horse is under you, that is touching the horse, this is the exact same area that the pudendal nerve supplies. So it can lead to fecal and urinary incontinence. It can be blocked by local anesthetic during childbirth, using an ischial spine as a landmark for injection. That's true. So we call this actually pudendal blockage. Some ladies are so afraid from the idea of an epidural anesthesia. So you suggest for them an pudendal blockage. Pudendal blockage means less pain, not zero pain. Epidural anesthesia means just compression. For the doctor to give this injection, he must first of all put his finger inside of the vagina and palpate the iliac spine. After palpating the iliac spine, he should put the needle exactly where his finger is. Of course, remove your finger and give the needle, okay? By giving the needle at that location, it basically means that you just hit the ischial spine. And this is good because there will be no ischial pain, which is going to facilitate the delivery, okay? Okay, but this is just an alternative. The way we would like to do it is actually an epidural anesthesia. Epidural anesthesia is going to block the whole region under in the legs, so even less pain for the lady. But as I said, not everybody is comfortable with the idea. Okay, guys, so I will see you guys in 10 minutes. See you in 10. Okay, everyone, welcome back. So the next thing we are going to speak about is going to be the knee. The knee is complicated. I mean, we have multiple ligaments in it. It contains, it contributes to multiple functions, and there is multiple clinical examination findings that exist in which you can determine which pathology does our knee have. So knee exam. First of all, I want you to know what ligaments exist in our knee. Maybe you have heard about something known as the cruciate ligament. Cruciate ligament comes from the word of the cross. Cross means it cross. So there is two ligaments that cross each other. One of them goes like this, and one of them goes like this. So as you can see, they cross each other. So we have here the ACL, which is anterior cruciate ligament, and posterior cruciate ligament. So From the lateral condyle, we have the anterior cruciate ligament. And from the medial condyle, we have the basically the posterior cruciate ligament. So you can see lateral femoral condyle to anterior tibia, ACL. The medial, PCL. Altogether is LAM. So lateral anterior and the medial posterior. So we have something known as the anterior drawer sign and something known as the posterior drawer sign. The anterior drawer sign was invented to check for the anterior cruciate ligament damage. Using that, you hold the leg with both of your hands and you draw anteriorly. And in case of the anterior cruciate ligament damage, the leg is going to let go with you and you will be able to pull it forward. If it's not damaged, it will not. So bending the leg at 90 degrees, anterior gliding of the tibia relative to the femur due to anterior cruciate ligament injury. So this is called the anterior drawer sign. There is something called the Lichtman sign. It's much more sensitive than the anterior drawer sign. It's the exact same, but instead of putting it at 90 degrees, you put it at 30 degrees. I mean the leg. So in Lichtman sign, also test the ACL, but it's more sensitive. Increase in the anterior gliding of the tibia relative to the femur, but you must bend the knee up to 30 degrees. Okay? So, posterior drawer sign. Bending of the knee at 90 degrees and posterior gliding of the tibia due to posterior cruciate ligament injury. So when we have a posterior cruciate ligament injury, the tibia will be allowed to go backward much more easily. Okay, so that's for the anterior and the posterior cruciate ligament. That was not that difficult. But now it becomes kind of difficult. It's not difficult, but you just need to understand the point. So the first thing first, we have something known as the abnormal abduction and abnormal adduction. So abnormal abduction. It's a way to check for MCL tear. Every time I get this thing, I always draw this just for the sake of understanding. So you need to know that the other leg is here, okay? So the other leg is here. So what do? You are going to bring the patient and you are going to try to put some force here. When you do some force here, if there is a tear, the leg is going to go like this easily. Why? Because there is a tear here. If no tear, this will be impossible to do. So also called the valgus stress test. So basically you are pushing the leg inward. So remember the gum, valgum, valgus, force. So knee either extended or at 30 degrees and you put a lateral force into the knee and basically you push from here and you pull from here. And the medial space widening of the tibia indicate MCL injury. Basically, if you take a look here and you see that, oh yeah, it's actually bending like this, that means that you truly have MCL tear. And the abnormal passive adduction, it's actually the exact same thing. Again, imagine the other leg is existing here. And they say that you try to do what? A Walross force, which remember the bottle of Rome here. So yeah, Walross. So you push it to this side and you pull this to this side. So that will show you the lateral, basically the lateral ligament, lateral cruciate ligament tear, if it does widen. The last two tests we can do, it's for checking of the meniscus. So what is meniscal injury? So, and what is meniscus? Meniscus is a disc, and we have two of them. So there is this two discs, as you can see here. You can see 1 and 2 lateral and medial menisci. And you can check for the function of them if they are intact or teared. Ah, nice picture. So you can see here the anterior cruciate, posterior cruciate, lateral cruciate, medial cruciate, medial meniscal, lateral meniscal, all in one picture. So, to check for the meniscus function, what do? You flex the leg. So this is the patient in front of you. You flex his knee in front of him. So you flex his thigh to his body, and after that you tell him to extend his knee a little bit, and then you are going to rotate the leg itself. So we call that the McMurray test. So again, you bring the leg upward, okay? Can you see this flexing position? Now is the time to do what? To rotate it outward or inward. If you rotate it outward, depending on the type of the rotation, you are checking for different thing, okay? So let's take a look. Okay, good. So as you can see here, when you push it like this inward, you are going to do what? You are going to create a force on the lateral meniscus, okay? So if it's stirred, you will feel pain there. And when you rotate it like outward, you are creating a force on the medial meniscus. So if there is pain, you are going to see like, well, it's going to be positive sign. In addition, it's going to rotate much more than it should be with you, you know? Because normally you should rotate until some point, but in this case, in actual problemo, it's going to rotate even more, okay? So this is a McMurray sign. They write during flexion or extension of the knee with rotation of the tibia and the foot. So a bane or bobbing sound on internal rotation and the Ross force, that means so internal rotation to the inside. So again, this one is going laterally, but yeah, when you do it to the internal rotation, if this was the leg, this is the leg, you do internal rotation, you are checking the lateral meniscus, okay? So if you have medial and lateral, and on internal rotation, okay, you are checking the lateral meniscus. Lateral meniscus tear, internal rotation stresses the lateral meniscus. So that's the line, lateral, internal, medial, external rotation. So pain or bobbing on the external rotation and valgus force, medial meniscal tear. External rotation stresses the medial meniscus. So again, anterior drawer sign, anterior cruciate ligament. Posterior drawer sign, posterior cruciate ligament. Abduction, base of abduction, it means medial MCL tear. Adduction, LCL tear. Internal rotation, lateral meniscal tear. External rotation, medial meniscal tear. Okay, you know when you were walking down the street and suddenly you sprained your ankle? It happened to all of us. So let's take a look at it. Ankle sprain. So you were walking and suddenly you did this, right? It feels horrible when it happens. And yeah, let's try to understand what is actually occurring. Anterior talofibular ligament is the most common ankle sprain overall. Classified as a low ankle sprain due to an over-inversion or supination of the foot, which means this, okay? So what are this ligament he's speaking about? So there is this ligament called the anterior, here they are. So we have this anterior talofibular ligament, and as you can see that goes something like this. An affection of this ligament and the tear of it, either this one can actually happen to any of these, but most commonly it's actually going to be with this guy, okay? But it can also happen in this guy, in this guy, in this guy, any of these. But this is just the most common one. They do ask you the exact name of the ligament, okay? It's most commonly to be one of these two. To be more fair, I believe that it was this one. So yeah, it can be one of these two, basically. Anterior talofibular ligament, the most common ankle sprain overall, and anterior inferior tibiofibular ligament, most common high ankle sprain. Okay, so we have high ankle sprain and low ankle sprain. Now I remember. So the high ankle sprain is going to be this guy, the one with the inferior. Low ankle sprain without the word inferior. Okay? Okay. So that is about ankle sprain. You know, all of us have this old lady in the family who comes and tell you that her back is hurting her. It doesn't matter which culture you are coming from, which community. which religion, nobody cares. All of us have that one aunt that comes to you and tell you her back hurts. And she keeps complaining about it. And you need to give her your medical opinion. She tells you, oh my God, my leg hurts so much. Like, I cannot sleep the night because of the pain of my leg. And you're like, yeah, what else is hurting you? You're like, well, except my legs, my back is also hurting me. Everything is hurting me. Well, anyway, if some patient tells you everything is hurting them, he's lying. But basically, the one with the legs, she's saying the truth. Probably she has some form of disc herniation. So we call anything that compresses the radix of the spinal cord. Radix of the spinal cord, remember, this was the spinal cord. There is this basically nerves coming out from it, and then they reattach together, which makes something known as the radix. And the radix then give the nerves, okay? So radiculopathy is a compression of the radixes. Paresthesia and weakness related to a specific lumbosacral spinal nerve. Intervertebral disc herniation, which occur most commonly posterior-laterally through the annulus fibrosus. So here they mention things like nucleus pulposus and annulus fibrosus. What do they mean? So when you speak about disc herniation, you need to know that the thing that herniates is actually the what is inside of the nerve, inside of the disc. So this thing, nucleus pulposus. Remember, the nucleus pulposus is the remnant of the notochord. And it's going to herniate and gets out and compress the nerve root of the spinal cord. And that is going to lead to radiculopathy. Notice it's going posterior laterally, which is the weakest portion of the annulus fibrosus, which is the thing going around the nucleus pulposus. So, they say, yeah, yes, intervertebral disc herniate posterior laterally through the annulus fibrosus into the central canal due to the thin posterior longitudinal ligament and the thicker anterior longitudinal ligament along the midline of the vertebral bodies, which makes it more easy for it to penetrate through it. Nerves affected are, is the one below. So it can be either one of these. So the herniation can be between L3, L4, L4, L5, or L5, S1. So if it was between L3, L4, who's herniating? I mean, which root of the nerve is affected? L4. Here, L5, here, S1. Remember, you look at the last one. Okay, so here L3 to L4, so you look at L4, L5, S1. Okay, personally, it was a pain in the ass for me to memorize all of this. So in the end, I just told myself a story. I just literally did it physically. I just stood up and tried to tell myself, okay, I'm standing up. Let me first of all try to imagine where is the pain, and according to that, I'm going to memorize it. I knew that it was only L4, L5, and S1 that I needed to memorize, but I needed to know which symptom for which one. So here they say weakness of knee extension, okay? So I just imagined myself standing up, my leg is extended in front of me, my leg is just flexed in front of me, and I want to extend it, you know? If I cannot extend it, it's L4, right? Again, I imagine that I'm standing up, I put my leg in front of me, so that's me. So this is me. That's me. Oh, okay. Okay, that's me. I wanted to memorize it by the following way. So I was like, okay, let me try to extend my knee. If I failed in extending my knee, that means it's L4, okay? If I fail to extend my knee, it's L4. Let's say that I have succeeded in extending my knee. I have succeeded in extending my knee. So that means my L4 is what? Is good or bad? Yes, it means that it's working perfectly. So this is my foot. This is my first foot, this is my other foot. If I was able to extend it like this, that means everything is all right. Okay, I was like, nice. So my L4 is working perfectly. Let me check L5. How to check L5? So I was like, okay, let me just dorsiflex my foot. Dorsiflex my foot to this side. So if I was able to do it like this, I mean, it was like this, but now I moved it like this. If I was able to do so, that means my L5 is healthy, right? And I was like, okay, since this is the situation, and I need to check if even I can walk on my heels, since I can expose it that easily. If I can do it, my L5 is perfecto. It's working normally. The last thing I was like, okay, now I checked my L4 by extending my leg. I checked my L5 by flexing, by dorsiflexing my foot. Now let me try to check my S1. For S1, I have to plantar flex down like this. And when after I did that, I was able to walk on my toes and dance ballet. Okay? So, again, extension of the knee, L4. A flexion of the foot, L5. A flexion, dorsiflexion, of course. Plantar flexion of the foot is S1. Okay, so they write weakness of the plantar flexion, difficulty in the toe walking, and decrease Achilles reflex. Good. So that's how it goes. Here they have neurovascular bearing, which means each nerve like to walk with arteries. No nerve like to walk alone. They like to walk in groups, multiple things together. So nerve and arteries are frequently named together by bone and region with which they are associated. The following are exception to the name convention. So mostly when we say like femoral, we can say femoral artery, femoral nerve. All of them go together. But here there are some things that are like not as you expect, you know? So that's why they put them. For example, in the axilla, we have something known as the long thoracic. And that supplies the and an artery known as the lateral thorax, which does not fit the like the names, you know. Surgical neck of the humerus. Remember, we said when it's fractured, you can have destruction of the axillary nerve, right? While the artery is going to be the posterior circumflux, which really has nothing to do with the humerus. Mid shaft of the humerus is going to be radial, and that will be the deep brachial artery. Affected if it's damaged. Distal humerus or cubital fossa, it was the median. By the way, remember the arm, right? ARM. The lower you go, the next nerve you are going to affect in case of the humerus. So if this is the humerus, axilla, axillary nerve, radial nerve, median nerve. Together they are the arm. The next thing is popliteal fossa, which is the back of your knee. It has the tibial nerve going through it, which is a branch of which nerve? What is the tibial nerve a branch of? The sciatic nerve, absolutely correct. And it's going to have popliteal artery. Finally, posterior to the medial malleus is going to be the tibial nerve as well, but it's going to have the posterior tibial artery. I know that these pages are full with memorization. I know it. There is plenty of stuff to memorize in these few first pages. But in the next few pages, now it's going to become much easier because it's physiology. It's more about understanding, not about memorizing. Okay, guys. So that's it for today. Tomorrow tomorrow is off. On Monday, we'll continue with physiology, and hopefully when we start pathology, this stuff becomes much more better, actually. So see you guys